So hello and welcome to this emergency podcast on DVTs. During this podcast I'm going to consider why DVTs are important for us to know about, the various risk factors associated with DVTs, important clinical features to be aware of, investigations that need to be done if you suspect a DVT, and finally the treatment and prevention. So firstly, why are DVTs so important? It's been estimated that between 25 and 50% of all surgical patients will have a DVT, even though greater than 50% of these will be below knee and totally asymptomatic. It is a fairly common condition. So the risk factors for DVTs we should all be fairly familiar with, the usual stuff. You can figure them out basically from Virchow's triad, which I'm not going to go through here. But the important ones to be aware of are genetic things such as thrombophilia that predispose to the development of DVTs, stasis, malignancy and infection, and obviously surgery itself. So important signs and symptoms now of DVTs. There may be calf warmth, tenderness, swelling, and erythema, plus or minus pitting edema. There may also be a particular eponymous sign called Hohmann's sign, which is increased resistance and pain on dorsiflexion of the foot. There is some debate, however, in the literature about whether one should perform this test, as it may dislodge a DVT, causing it to embolize. The important tests to do when you suspect a DVT are a D-dimer and ultrasound. There are some specific points that need to be made, however, about both of these tests. The D-dimer is a test that is sensitive but not particularly specific. In practice, this means that a positive D-dimer when you suspect a DVT is not very useful, as often other things such as infection, malignancy, and even being post-operative can cause this. A negative result, however, with a low clinical probability of DVT is useful, and together these two features can be used to exclude the diagnosis. Ultrasound as a second-line test is incredibly useful, and if negative with a high clinical suspicion should be repeated 1 week after the initial scan. Venography can be performed to definitively diagnose DVT, but is rarely necessary. So from a management perspective, I'm going to talk now a little bit about management of an acute DVT and prevention of DVTs. In preventing DVTs, the most important things you can do are to mobilize early post-operatively, to wear stockings, and to take low molecular weight heparin. An example of a low molecular weight heparin that's commonly used is enoxaparin, 20 milligrams every 24 hours subcutaneously, starting 2 hours pre-op. It's also important that the oral contraceptive pill is stopped 4 weeks before the surgery. Of course, patients should be advised to use other forms of contraception during this period. In extreme situations where there is recurrent DVTs, despite aggressive medical treatment, it may be necessary to use pressure boots until 16 hours post-op. Once a DVT has occurred, all the most recent evidence points to starting warfarin. I'm going to do a podcast on this in the future, but basically you need to start low molecular weight heparin and warfarin at the same time. An example of a low molecular weight heparin you might use would be enoxaparin, 1.5 milligrams per kilogram every 24 hours. Now, you would monitor the INR once you started both of these drugs and stop the low molecular weight heparin when the INR was between 2 and 3. You'd want to continue this treatment for 3 months post-operatively, 6 months if no other cause of the DVT was found, and for life if there were recurrent DVTs or thrombophilia. The one exception where you cannot treat patients with low molecular weight heparin is an iliofemoral thrombosis, as the evidence is extremely limited. In this situation, you would use unfractionated heparin and monitor the APTT. So that completes this short podcast on DVTs. In a podcast to follow, I'm going to have a detailed look at pulmonary embolism